We should also be reminded that for some patients, these CDK4 inhibitors represent a bit of an inconvenience. Not all of them need these drugs necessarily. And for those of us who practice in areas that we serve rural communities, to come every month for a blood count sometimes can be complicated. So we're finding out that, for example, for the PALA study, which is an adjuvant trial,
yes, it's a good
some
trial.
patients, it's a great study, I agree, but some patients are turning it down because they're not being treated for metastatic disease, just for adjuvant disease. So they're thinking twice whether they want to commit to the visits and blood testing that the trial requires.
I mean, I think you've hit on something here that's important. The patients aren't paying a clinical price, but they're paying a financial price. And I think that's really what this comes down to. If this drug was Ribo or Palbo, or whatever, maybe Abema, we're going to talk about in a few minutes. If these drugs were, $100 a month, we wouldn't be having this discussion. They're $10,000 a month, roughly, U.S. And so, the issue is that there's clearly, and if there's a survival benefit, Debu, if it turns out there's a survival benefit, will we have to use these drugs in everybody, regardless?
Well, we're using them, I must say, in a vast majority of our patients. Many times I get asked, is there a subpopulation that you think does not need CDK4/6 inhibition up front? And I'd like to know if anyone else on the panel feels that way, but I don't know of any factor other than convenience and cost that would identify such patients.
Kim,
Yeah.
do you give to everybody?
Pretty much. And people argue like, isolated bone mets or long disease-free interval, but since adjuvant therapy. But if you look at the subgroup analysis on the studies where we have the most mature data, Paloma 2 and Paloma 3, I mean, the women facing bone-only ER-positive breast cancer derive just as much benefit as the patients facing heavy burden of visceral disease. So just from a pure efficacy standpoint, I've not been able to define a subgroup of patients. Now, Carlos raised a good point, the patient that doesn't want to come every 2 weeks, at least for the first 2 months and every month. I guess my experience has been when a woman is diagnosed with a recurrence, they like to come to my office every 2 weeks for the first 2 months. We have a lot to discuss. Yeah. They're in the midst of a crisis. We're usually trying to get their bone health agent approved. There's just a lot going on. So, I don't think the actual visit has created much more of an inconvenience than what we would see in the old days.
And think of the alternative. I mean, these are patients that classically would have received chemotherapy much earlier, right? Mm-hmm. And there is no comparison. I mean, the quality of life is...
Well, that's a really good point. I mean, and that's a point we really need to emphasize. I mean, I think that, again, I'm assuming most of us on this panel, and we should ask everybody, are believers in the whole visceral crisis concept of chemotherapy. That is, you don't treat someone with chemo in this setting unless they really are like, a month or two away maybe from having liver failure or whatever. I mean, do people believe that? Denise, are you a believer in visceral crisis for chemotherapy?
Yeah, I think that there's a certain group of patients that, chemotherapy may be a more appropriate choice to rescue that patient.
Right, but I mean, the issue is someone comes in with a couple liver mets, or asymptomatic, maybe a couple 1, 2, 3 centimeter liver mets, a few lung mets, maybe had a pleural effusion that's been drained or has a pleurax in, Those are people normally, I think in the past, we would have given them chemo. And now I think, would most of us here do a CDK4 and hormone therapy?
Yeah, my thinking about that was heavily influenced. There's a preoperative study that was presented at San Antonio in 2016, and they compared the use of an AI alone versus a CDK inhibitor, it was Palbo, I think. And what they saw was, close to 90% reduction in Ki67 at day 14 biopsies. That's as good as we see with chemotherapy, certainly. So the thing that I like about patients who are symptomatic from their disease is we know these CDK inhibitors kick in fairly quickly, whereas the AIs can take a matter of weeks. So again, I think that's a potential benefit for a symptomatic patient to adding these drugs. And I agree with Jose that the price of chemotherapy is a horrible one, not only for the patient, but the cost, and anything that kicks that can down the road by a matter of months is worth it. I don't necessarily need to see a survival benefit for these drugs.